So the next section I want to talk about is intra-op nursing, or what happens in the OR. For us as nurses, when patients go into the operating room where they're going to have that procedure done, our number one priority is keeping our patients safe. That is the big deal. We're going to put them into an unconscious state where they're not able to advocate for their own needs anymore. So we need to be the ones paying attention to what's going on with them so that we can advocate for those needs that they may have, like keeping them safe. So some of the people you're going to see in the OR, these are the four main categories of nursing roles that there could be. So the circulating nurse is the most common one. This is a nurse who is not sterile. They're not scrubbing in for each procedure. What they're going to do is they're going to prepare the room prior to the surgery, making sure all the equipment is there, making sure all the supplies are ready. And then they're going to remain in the unsterile field. So the area kind of in the background of the operating room, not participating directly in the procedure. They're going to be doing documentation and getting any supplies that may be needed while the procedure is going on. Then there's the scrub nurse role. Honestly, this isn't really a nursing role anymore. Most of our scrub people are technicians. Because this is a sterile role. These are the people standing kind of hip to hip with the surgeons, handing them instruments. So when the surgeon says scalpel, the person handing them the scalpel, that's the scrub tech. In rural settings, you may still see nurses in this role, but primarily it is a technician role these days. So they're going to be preparing the instrument table, making sure all the appropriate instruments are properly prepared, passing instruments to the surgeon, and they're going to be in the sterile environment. So they are scrubbed in, ready to assist should it be needed. Then there's our surgeon's assistant. This is very, very rarely a nursing role. Usually this is filled by a physician assistant or somebody in the medical model of training. These people are going to assist the surgeon with basic tasks that need to be done. So things like holding the retractors to keep the patient open while the surgeon can do their work, assisting with hemostasis, meaning monitoring for hemodynamic stability, getting any orders prepared for fluid boluses, blood transfusions, things like that while the procedure is going on. And then final suturing. So a lot of surgeons really, they don't do final closure on their patients. So they're going to be doing, usually the surgeon will do closure up to the fascia of whatever procedure is being done, but the final closure, meaning like the final skin closure, can be done by a surgeon assistant. And then there's our CRNAs, or our anesthesiologists. This is an advanced practice nursing role as a CRNA, which is a certified registered nurse anesthetist. So these people are going to be the ones who are really in control of the anesthesia or making sure the patient stays sedated for the entire procedure. Other jobs they have is monitoring for cardiac and respiratory status to make sure that the patient stays stable throughout the entire procedure. But this is kind of what their work area looks like. If you guys get a chance this rotation when you're in the OR to see this role, it's a good one to take a look at just to get an idea of what the role, responsibilities, when are the busy times, and when are the not so busy times. Next, we want to start focusing on environmental safety. So a big part of this focus on safety is we need to know who the people are in the room, and then where is it appropriate for these different people to be working. So environmental access is a really, really big deal in the OR. This means that at different stages in the OR process, different people should have access to those areas. So the first areas are unrestricted areas. This is where street clothes are appropriate. Patients' family members can come into this area. When we're working in these areas, we can wear regular scrubs like that we bought and we wash at home. And this includes like nurses' station, pre-op area, and the PACU environment. So any place where the procedures are not actually happening, but we're either preparing or recovering our patients. Then there's the semi-restricted area. This is kind of like the actual unit inside the OR where all the different OR suites are. And this is an area where you have to be wearing surgical attire. That means the scrubs that the facility provides. It also means that your head needs to be covered with the little kind of blue hat. Also your shoes need to be covered, so it's like full on Smurfland. The reason for this is that this is an area where you're encountering people who are going to be working on patients. So we can't allow people to be bringing in environmental contaminants or bacteria into these environments, which could possibly contaminate our patients. Part of the reason for the surgical attire is that so visually, from down the hall, we can recognize people who should or should not be in these environments. Then getting a little more focused, we're into the surgical suites. So these are like the individual rooms where the procedures are happening. Surgical attire is required in these areas. That way we all know who is prepared, who has cleaned themselves appropriately, and who's dressed appropriately for these high-risk procedures that patients are going to be exposed to. We're trying to minimize the potential risk that patients are going to be exposed to while they're in these environments. And then getting even closer, so within the room that the surgery is happening, the sterile field is really the only part of the OR that is actually sterile. So the sterile field is like all the draping, all the coverings, where the surgery is actually happening. So if you had an imaginary line going like shoulder to shoulder around the operating table of all the people who are helping with the procedure, like the surgeon, the surgical tech, the anesthesiologist, kind of that kind of area, that's the sterile field. It really doesn't extend more than like a couple feet out from the side of the operating table. So it's actually a very small area within that surgical suite that we consider the sterile field. And this requires sterile scrubbing. So people who are working in this area, they do need to scrub in. They need to do that detailed scrubbing in of all skin extremities, elbow to fingertips. And then our goal here is to minimize and eliminate all the microbial contamination that could take place in that environment. For the circulating nurse, one of the big things that we want to focus on, since that's the primary nursing role in the OR, is we want to start looking at those environmental safety things that are going to impact the patient while they're unconscious. This includes things like positioning. So one, getting the patient over to the operating table. Sometimes patients will be wheeled into the OR while they're still conscious, and they can participate in a transfer from gurney to bed. Sometimes they can walk straight into the OR and place themselves on the operating table. Other times the patient's going to get into the operating suite and already be sedated. So then we're going to have to really monitor that patient for safety around that transfer, because they're just going to kind of be a lump of human, and we'll need to kind of keep a closer eye on them. And then the safety precautions once they're on the table. So here's a patient who's on an operating table. One of the things we do, because they're sedated, I'm sure you guys have had experience with like a roommate or a friend who's been like passed out or for whatever reason, and you need to move them around. Like they're just a lump of human. If you lay them down, like odds are they're going to kind of blob wherever they need to go. So we strap patients down in the OR to the OR table when they're fully sedated to prevent them from kind of blobbing or rolling their way off the operating table onto the ground. Here's an example of one of the straps kind of going over this gentleman's arm. For very, very long procedures, like multiple hour-long surgeries, I have seen circulating nurses help to kind of reposition straps across a patient to prevent skin breakdown from where we're securing them to the tables. And then make sure the wheels are locked. Weird thing about hospitals, unlike every other place in the world, is we put wheels on all the furniture. It's weird. It's just a thing we do. But we always need to make sure those wheels are locked. One of the scariest things I ever did when I opened up an OR, surgeon was about to make his first cut, walked up, put his kind of hips against the table to lean in, and the whole table started moving as he was leaning in to start doing his cut. It's like, time out, stop. Let's lock this thing down and start all over again. It was super scary. The other big thing, we want to watch all the lines. These are all the tethers that are attached to a patient. Lots of IV lines, oxygen lines, lots of monitoring equipment. We want to tidy that up as much as possible and make sure that it's safe. And then application of all our monitoring devices. So all those tethers that we're attaching to our patients. There's going to be an EKG machine monitoring their heart activity, blood pressure cuffs, pulse oximetry for our vitals machines, perioperative nerve monitoring and BIS. So these are systems that are designed to measure the level of sedation. They're almost like electronic neurologic monitors so that we can tell if a patient, or start to predict whether a patient is starting to wake up during the procedure. Usually the anesthesiologist monitors the output for a lot of this equipment. So again, for our patient safety, it's important for us to keep in mind like what level of anesthesia our patient is undergoing. So general anesthesia is complete sedation. So our patient's going to be completely unconscious. They're going to be getting sedatives, paralytics, opioids, the works. All the drugs is what they're going to be getting. Because they're sedated and paralyzed, these patients don't have the capability of protecting their airway, meaning there's a very, very high risk of aspiration and obstruction of their airway. One of the big ones is actually from the tongue. Tongue's just a big muscle. So when we paralyze it, there's a big risk of almost that sleep apnea kind of presentation where their tongue can fall back in their mouth and actually occlude their airway. So we do need to do airway support for these types of patients. Our most invasive intervention for airway support is full intubation, where we put a tube in the mouth down to about this level in the throat, in the trachea, and then we inflate a cuff, and that keeps the airway opened. One step less invasive is our LMA, which is this device here. So unlike an intubation, which is just a tube that goes all the way in, this is kind of a large surface area. It only goes to the epiglottis, so the oropharynx, or kind of the pharynx down in here. And then we inflate this device, so it's a less invasive version of an airway. And then our least invasive is our OPAs, so oropharyngeal airways, which are those little devices that just kind of go right up here in the upper airway to keep the tongue from occluding the airway. Because these patients have the highest level of sedation, they're getting the most drugs to achieve that sedation, this is the type of anesthesia that is most prone to having complications associated with it. So these are the patients that we need to pay particular attention to for safety when they're in the OR. Another type of sedation that we use are regional sedation areas. So these are like nerve blocks. So the most common one you guys will experience is in OB with women giving birth who are getting epidurals. That's a nerve block for their lower extremity, for kind of mid-torso down. Orthopedic surgeries use nerve blocks a lot. So we're going to be using general anesthesia to sedate the patient. Then they'll also be getting a nerve block to whatever extremity is having like a joint replacement done. So patients getting a knee replacement will get a nerve block of that entire knee while they're also getting general anesthesia. These ones, we need to do our 5P assessments, which you guys will learn about in the PACU section. So we do need to be doing focused assessments on those extremities to make sure that neurologically they start to regain feeling and remain intact as much as possible. Then local anesthetic, this is only at the site of injection. So these are stuff like when you go to the dentist office, like lidocaine, novocaine, things like that. We use lidocaine to inject that intradermally if we're doing specific procedures. An example of this would be like the thoracentesis that we learned about in the respiratory section when we talked about chest tube insertion. We can do local anesthetics at the site of insertion so that patients don't have discomfort around those needles being inserted. So conscious sedation is our last type of sedation. And with conscious sedation, like this is the kind you're familiar with. It's the kind that people get when they get their wisdom teeth taken out or a lot of other day surgery type procedures. For conscious sedation, the patient is not going to be fully asleep. They're still going to be cognitively intact and able to communicate with the team that's doing the procedure on the patient. It's a combination of drugs that are given. Usually we give fentanyl and Versed. Fentanyl is kind of the opiate, it's the CNS depressant agent. Versed is an agonist drug, but it really helps the patient to not remember a thing about what is going on. But our patient will remain semi-conscious and able to give us feedback during that procedure. So when we talk about assessment and how we keep our patients safe while they're in the OR, the big thing we're focusing on again is safety. That's the big deal in the operating room. And the way we do this is with our focused exams. We are not doing our head-to-toe exams because we don't have that kind of access to our patient. They're underneath the sterile drapes, they're having a procedure done. We can't get in there and do a really full assessment. But we are focused in on specific aspects to know that it's safe. So for example, our neuro exam, we're gonna be doing those frequently. And I'm not talking about like A&O status or GCS assessments. We wanna make sure that the level of sedation that's being applied to our patient stays intact throughout the entire procedure, that they don't start waking up during the procedure and having some pretty negative experiences as a result of that. Our respiratory exam, again, we don't have access to listening to the patient's lungs, but we do want to make sure that they have a regular respiratory rate and rhythm and that they're oxygenating okay, so that their SpO2 is within normal ranges, that they're able to maintain a patent airway. And then our cardiovascular exam, so again, we're going to be checking vital signs, heart rate, blood pressure, specifically for our cardiovascular, and to make sure that our patient maintains that hemodynamic stability while they're having that trauma kind of done to them. And the way we do that, again, we need to assess their vital signs. We're going to be getting vital signs at a minimum every 30 minutes during an operation that they're having. The other big thing we do for safety is the sterile field. We need to know where the sterile field is, and we need to defend it. So when we look at the OR, the sterile field is really that area right next to the patient. So we need to make sure that no inappropriate equipment or personnel are violating that sterile environment. So we need to know exactly where the boundaries are. And defending it, think back to when you guys did your sterile gloving in health assessment, in foundations. So is it a big deal when you contaminate your sterile gloves? No, it's not a big deal. It's a big deal if you contaminate and don't recognize it. So we're looking out for contaminants that may be introduced to our sterile team and pointing those out, because we do want to make sure that if there is a contamination or a breach of sterility, that all they do is just change gloves, re-sterilize so the procedure can go on in a safe manner. So for our nursing diagnoses, we've got a lot of risk for things that are going on. The problems that we're cued into, our patients are at risk for these problems. So things like risk for impaired gas exchange because of poor oxygenation, risk for altered breathing pattern because of the sedation medications again. One of the few actual diagnoses that we're going to be managing is now they have impaired skin integrity because of the surgery. The surgery has given them that skin integrity impairment, so we want to be cognizant of that. Oops. So then, for the plan, when it's all going well, these are the things that happen. We do a timeout before the procedure starts. A timeout is exactly that. It is literally right before the surgeon cuts the patient to start the procedure, anybody on the surgical team can say, timeout. And what they do is they go through a checklist and check all the safety elements that need to be in place for the procedure to go well. That includes things like the right patient, the right surgeons, the right equipment, the right staff, that everything has been accounted for prior to making that incision on the patient. It's almost like our 5 rights with med administration, but instead of giving meds, we're giving a procedure, but we still do a lot of those same types of checks. Other things that can be added on, smoke particle evacuators. These are necessary for the OR suite because of the electrocautery equipment. So the electrocautery is like that cauterization knife that they use. What it does is it burns the skin very mildly as they cut the skin, helps to reduce the risk of bleeding in patients. But because it's kind of burning as it's cutting, all of the sterile drapes, which are paper, very high risk for fire. So we do need to make sure that we're managing that appropriately. Any grounding pads for electrical connections, and that our patient is positioned appropriately before we get into the surgery. If you guys haven't seen a timeout procedure, there's a link right here in your presentation. Definitely want to check that out. It's a good training example of a really good checklist-oriented timeout procedure. When things are going bad, we experience complications during surgery. Things like wrong site surgery, wrong procedures. This still happens about 100 times. I think in 2018, I think there were 97 wrong site surgeries done in the United States. It's not a huge number when you think of how many procedures are done every year, but 100 times we did the wrong surgery on a patient. Not super awesome. These two can go hand in hand because the way surgeons work is they book the OR for the day. They're doing many procedures on many different patients, one room to the next room to another room. So we want to make sure that the surgeon is going into the right room for the right procedure, not just kind of wrapped up in the pacing of their schedule. Foreign bodies and physiologic instability, this is really the land of nursing. So the circulating nurse, they are very concerned about these two things and looking out for the safety of our patient around these. So foreign bodies, one of the main jobs of the circulating nurse is to account for all the instruments and all the equipment that's been provided to the surgical team and to make sure we get all of that stuff back before they do final closure of the patient. Most of the equipment that's used in the OR is what we call radio-opaque, meaning that if we need to take an X-ray of our patient, it'll show up on X-ray, which is really helpful. But even more helpful is that we keep track of it so we don't have to do those X-rays and look for it. And then physiologic instability, we're looking for respiratory stability, so respiratory rate, oxygenation, and hemodynamic stability, again, our blood pressure and our heart rate. So that brings us to the ugly. So we've got the good, timeouts. The bad is when kind of the complications around surgery occur. And then the ugly is where it's all gone wrong. It was like worst possible outcome. And the big ugly thing that we can encounter in the OR is malignant hyperthermia. This is a life-threatening reaction to anesthesia that's provided to patients. So what happens is there's a hypermetabolism in the skeletal muscles as a result of altered calcium levels, and that tonicity causes the body temperature to rapidly elevate. We're talking about temperatures greater than about 104. So very, very, very high temperatures. And one of the things we know about high temperatures greater than 104 is that's when cellular death can occur. So big, big deal. This is a life-threatening emergency. It's also, there's a genetic component to it. This is why during pre-op assessment, during our review of systems, it is so important to ask about past surgical history, how they tolerated anesthesia, and also their family surgical history. Has anybody in their family had surgery? Did anybody in your family that you know of have a hard time dealing with anesthesia? What we're looking for is there that genetic link to the patient that we're working with that they might have this malignant hyperthermic reaction? If patients have this, it's not likely that they will. It's not common at all. 10 years of practice working with OR patients, I never saw this happen. But we do have a special code cart. So there's the code cart for regular resuscitations like respiratory arrest, cardiac arrest. Then there's a separate one for malignant hyperthermic reaction. It's all the equipment we need should this very rare but very lethal complication occur. One of the big things we want to look for is dantrolene, which is our drug that can help with the reversal of this condition in our patient. But this is a very, very serious complication that we start evaluating for in pre-op, and we need to be extra diligent about monitoring for its presence while the patient is actually getting their procedure. Again, we've got a video link here that kind of goes through exactly what goes on during a malignant hyperthermic reaction. So for implementation, the big things that we're actually doing, the big actions, are we're verifying that a lot of safety interventions have been done for our patients so that it's safe for them to have the procedure they're going to have. So first thing, has the surgical site been properly sterilized? The chemicals that we use to sterilize the skin, so this is called the surgical window, and this whole area where the patient is exposed to have their procedure done needs to be sterilized. The two chemicals we use, one is chlorhexidine or CHG, which is our ChloraPrep. The only difference between this stuff that we use in the OR and the stuff we use all over the hospitals, we dye it blue in the OR. That way we can just visually see what we've cleaned. If patients have an allergy to CHG or chlorhexidine, then we'll use iodine. And iodine, as you guys know, it turns the skin orange, kind of goofy looking. Big thing with both of these chemicals, if you leave them on the skin for a prolonged period of time, all of them can cause skin irritation and actual skin burns, like mild burns in our patient. So one of the big things we want to take care of anytime we're working with patients, especially in that way post-operative period when they're back to a care environment, is make sure we clean these chemicals off of their skin. Once we ensure that this window, the surgical window, has been sterilized, we need to make sure that sterile draping is appropriate for the procedure that's being done. So do the surgeons have all the equipment they need to outline their surgical window and prepare their sterile environment? So everything in blue in this operating suite is sterile. That's our sterile field, starting from the incision and working our way out. But you can see it only extends just a little ways out from where the patient actually is. Behind the surgical tech and the surgeon, that's not a sterile environment anymore. And the anesthesiologist lives back here behind the curtain where all the equipment is and the patient's head, managing the airway, managing all the sedative kind of equipment. Oops. So again, for evaluation, because priority number one is safety, our evaluation is, was our patient safe throughout that procedure? The big tools that we use to ensure that that's done: checklists, pre-op checklists, OR checklists. Our timeout, our safety timeout that's done in the OR, it's a checklist. So there's a lot of, this is an example from World Health Organization of several different checklists, all of which take place in the OR. So these are all the things that are done before the induction of anesthesia. So this is kind of our pre-op checklist. Then before the skin incision, so before the surgeon makes their first cut in the patient, all of these things need to be verified that they're in place and accurate. This is our timeout, done right before the surgery starts. And then our final checklist, this one takes place right before the patient leaves the operating room. So the circulating nurse will go through these criteria and verbally confirm that the patient is safe to leave this acute environment where they have lots of support for their physiology, so hemodynamic support, respiratory support, and will they be safe to recover from this procedure? So that's one of the ways, using all these checklists, is how we ensure that all of our patients stay safe, regardless of the type of procedure they have, or regardless of all the different surgeons or other members of the healthcare team that are working with those patients in that really sensitive environment. That's it for OR nursing. Next comes PACU, or the recovery room for surgery.